For our DNP project, we conducted a systematic review regarding the use of erythromycin to reduce aspiration in adults undergoing general anesthesia. So why are anesthesia providers concerned about aspiration? While anesthesia is generally safe, aspiration during induction of general anesthesia is a potentially fatal complication that is associated with pulmonary injury and subsequent respiratory failure. Aspiration is defined as the entry of liquid or solid material into the trachea and subsequently the lungs. The administration of anesthetic agents results in loss of consciousness, thus blunting one's normal laryngeal protective reflexes. Passive or active regurgitation of gastric contents can then ensue, leading to bacterial infection or pulmonary injury, which prolongs hospital stays and increases incidence of morbidity and mortality. For this reason, patients are asked to fast for a predetermined number of hours prior to undergoing general anesthesia for surgery. Aspiration is estimated to occur in about 1 in every 2,000 to 3,000 operations requiring anesthesia. Current practice for minimizing risk of aspiration varies among providers. Pharmacologic agents such as metoclopramide, domperidone, or cisapride are administered by some in the preoperative period to increase gastric motility. These current pharmacologic agents have resulted in serious adverse effects. Metoclopramide, for example, may cause restlessness, extrapyramidal effects, or contribute to causing serotonin syndrome when combined with other medications. Physical maneuvers, such as the application of cricoid pressure, may also be performed to reduce the risk of regurgitation by occluding the esophagus. A systematic review conducted in 2007 demonstrated that with the use of cricoid pressure, the esophagus is displaced relative to the cricoid in 50% of patients, deforms the cricoid in 90% of patients, and obstructs the airway in 50% of patients. Erythromycin is not a new drug. It has been around for decades, however not used for this purpose. Science, healthcare, and technology have continuously relied on constant innovation and application of evidence-based practice. Innovation allows healthcare professionals to offer improvements in care. In 1962, theorist and sociologist E. M. Rogers developed the diffusion of innovation, or the DOI theory, to explain how new ideas or products gain momentum. E. G. Rogers' diffusion of innovation theory can be used to explain the incorporation of erythromycin into practice. In his theory, he included 5 key components: the innovation, the adopter, the social system, the individual adoption process, and the diffusion system. These components explained that first, an idea or product must be developed. Once developed, someone must adopt the innovation. Then, the innovation should be utilized somewhere in a social system. Next, various others within the social system would determine whether or not they desire to adopt the innovation. Finally, the innovation could then propagate and diffuse. Aspiration is a potential complication of general anesthesia. We conducted the systematic review to introduce erythromycin as a potential intervention for minimization of risk of aspiration. Through synthesis of existing literature and studies, our systematic review answered this question. In adult patients undergoing surgery, does administration of erythromycin prior to induction of anesthesia reduce the risk of aspiration?
The first criteria for studies in review were the types of participants. Studies with adult subjects 18 years and older were included. For example, healthy fasted and non-fasted subjects, patients with acute pain, emergency trauma patients, ventilated intensive care unit patients, critically ill patients, and elective ambulatory surgical patients. Studies involving pediatric patients were immediately excluded. A PICO search strategy chart was utilized to assist in locating, assessing, and evaluating relevant studies. The types of interventions included all doses and forms of erythromycin with suspected effects on gastric content and acidity prior to induction were included. Comparisons included a placebo, nizatidine, metoclopramide, domperidone, cisapride, or combination of treatments such as metoclopramide erythromycin, ranitidine erythromycin, and ranitidine metoclopramide. Outcome measures for reducing the risk for aspiration included quantitative measurements of gastric volume, gastric acidity, gastric emptying rate, peak blood alcohol concentration, and small intestinal transit time. Participants' perception of symptom severity as they relate to strong prokinetics was also measured. Dyspeptic symptoms were reported utilizing a qualitative scale, which ranged from postprandial fullness to epigastric burning. And lastly, the types of studies included peer-reviewed studies describing the effects of the erythromycin on gastric content published between January 1990 and December 2019, written in English, were included in this systematic review. In total, 11 studies evaluating the use of erythromycin were utilized. These studies included 1 single-blinded randomized control trial, 6 double-blinded randomized control trials, 1 prospective non-interventional case series, and 3 crossover trials. Studies with poor design and methodology or data collection analysis, such as case reports, were excluded. Likewise, quantifying the influence of erythromycin on qualitative symptoms and/or side effects was outside the scope of this review, thus like studies were excluded. Methodical and comprehensive literature search was performed by 2 doctoral nurse anesthesia students. The dyad met with the university librarian to ensure that the search incorporated search terms that were concise and appropriate to the chosen topic. Multiple databases were utilized, including CINAHL, Medline, ProQuest, Ovid, Quotient, and Science Direct. Search terms included adults undergoing surgery, adult surgical patients 18 years and older, IV erythromycin, macrolides, IV erythrocin lactobionate, prokinetic drugs, perioperative antibiotics, aspiration, regurgitation, pulmonary aspiration, laryngeal and lower respiratory tract aspiration, gastric volume, and gastric emptying. Studies were selected for inclusion in this review with the assistance of the depicted prism diagram. Using key terms when conducting the database search, 61 records were identified initially. 6 additional studies were found outside of database searching. After duplicates were removed, 62 studies were considered for inclusion. When considering records for inclusion, studies were initially screened by analyzing their title and abstract. Studies involving pediatric patients or studies published in foreign languages were immediately excluded. 48 of the 62 studies were excluded. Thus, the 14 remaining full-text studies were assessed for eligibility. All 14 studies were screened in depth by 2 independent reviewers with the use of the Joanna Briggs Institute Critical Appraisal Checklist. Critical appraisal of these studies involved assessing presence and adequacy of randomization or blinding, outcomes measurements, statistical analysis methodology, demographical data, and various other components. Each step or question in the checklist was answered with a yes, no, or not applicable response. At the conclusion of the checklist, an overall appraisal was determined to either include, exclude, or seek further information on the study. 3 studies were excluded after conducting a critical appraisal. 1 study was excluded due to inclusion of the participant 16 years of age. The 2 other excluded studies failed to detail methods of data collection and data analysis. As such, the studies were excluded due to lack of validity. The 11 utilized studies focused on the use of erythromycin in addition to other prokinetic agents for gastric emptying in adult, surgical, and critically ill patients. The investigators of this systematic review identified 2 themes, the first being related to erythromycin's use for emergency surgery. Erythromycin 2 to 3 mg per kg IV was associated with increased rates of gastric emptying in emergency surgery patients. 1 study administered 3 mg per kilogram erythromycin, and the other administered erythromycin 2 mg per kilogram. Within 10 minutes of administration of erythromycin, gastric emptying rates increased by 17%. Investigators concluded that in the patients undergoing general anesthesia for emergency procedures, erythromycin can be administered to both clear the stomach and decrease acidity of residual gastric content, thus reducing the risk for damage should pulmonary aspiration occur. The results from the included studies suggest the second theme, involving the use of either IV or oral erythromycin prior to induction of anesthesia is effective for increasing gastric pH, increasing gastric motility, decreasing gastric content, and decreasing the risk of aspiration in non-emergent elective surgery in adults. While there are alternative medications currently on the market for these indications, such as cimetidine, ranitidine, famotidine, nizatidine, metoclopramide, droperidol, limperidone, or cisapride, studies have demonstrated that erythromycin is more effective and has less incidence of unwanted side effects. Gastric emptying rates were increased following erythromycin's administration via activation of motin receptors and possibly via vagocholinergic nerve stimulation. Erythromycin has also been shown to be more efficacious when used in combination with other drugs known to increase gastric motility, such as metoclopramide erythromycin and ranitidine erythromycin. Furthermore, Narsi et al. And Asai et al. Have shown that side effects are dose dependent. Thus, low-dose erythromycin 200 to 250 milligrams oral or IV administered 1 hour prior to induction of anesthesia reduced the risk of aspiration by minimizing gastric volume. In summation, erythromycin has proven to be effective at increasing gastric pH, increasing gastric motility, and decreasing gastric content in a variety of populations, including but not limited to patients with acute pain, patients with gastroparesis, patients who are critically ill, and surgical patients undergoing ambulatory outpatient, elective, or emergency procedures. The results of these studies suggest that erythromycin 200 mg oral or IV 1 hour prior to induction of anesthesia should be considered in adult surgical patient populations at risk for aspiration of gastric content. Strengths of the included studies are as follows. All test subject characteristics were provided in tabular format. Inclusion and exclusion criteria were detailed. Standardized method of induction were utilized, and meticulous statistical analysis were performed. Additionally, a vast majority of the appraised studies were randomized controlled trials, which helped ensure a balanced distribution of potential known and unknown confounding factors. Studies were performed in various countries, including Belgium, Japan, India, France, Switzerland, Australia, Israel, United States, Germany, and Turkey. Additionally, many of the researchers tested erythromycin under multiple conditions, for instance, various time frames of administration, dosages, and routes of administration. The consensus was that subtherapeutic doses of 200 milligrams erythromycin or 3 milligrams per kg erythromycin 1 hour prior to induction of anesthesia significantly reduced gastric volume and acidity while lacking side effects. Noteworthy strengths of the included double-blinded studies were the utilization of placebo tablets for the control group in order to maintain blinding of both the test subjects and the investigators. Reliable tools of measurements were also used throughout, which included endoscopic for qualitative and quantitative assessment of gastric content, multiple orifice Salem sump gastric tubes and syringes for measuring residual gastric volume, and pH test papers or digital pH meters for assessing acidity. Additionally, a multitude of comorbidities and medical surgical settings were investigated to help generalize the results. For example, fasted and non-fasted patients, emergency trauma surgery patients, healthy patients undergoing elective surgery, ventilated intensive care unit patients, and ambulatory surgery patients. Limitations and challenges throughout the studies included limited evidence regarding optimal prokinetic dose of erythromycin, dosing schedule, and long-term efficacy of erythromycin's use. Additionally, some of the included studies had small sample sizes and lacked randomization. The authors of this systematic review sought to determine whether the administration of erythromycin prior to the induction of general anesthesia would reduce not only the risk of aspiration, but also the detrimental effects associated with aspiration should it occur in the adult surgery population. Literature dating back to the 1990s have demonstrated that erythromycin has been an effective prokinetic agent, yet sufficient literature does not exist regarding routine administration, dosing of erythromycin, or long-term implications of erythromycin. Thus, what the investigators of this systematic review concluded is that erythromycin is low in cost, possesses a safe pharmacological profile, and most importantly has been validated to effectively reduce gastric volume, thus minimizing risk of aspiration upon initiation of general anesthesia. Furthermore, if a patient were to aspirate, erythromycin's effects on reduction of gastric pH could diminish complications associated with chemical pulmonary injury. Large-scale studies should continue to be conducted to determine optimal dosing of erythromycin for aspiration risk reduction, in addition to determining any potential long-term implications of erythromycin's use, such as antimicrobial resistance. The literature currently supports a practice change to more effectively combat aspiration prior to induction of anesthesia. Despite the use of rapid sequence induction by some providers, there has been no standard practice defined for minimizing aspiration risk. The findings from the studies included in this systematic review have demonstrated that erythromycin was more effective than metoclopramide. The writers of this systematic review do not currently recommend that a new policy be employed, as evidence is not strong enough to support widespread application of erythromycin's use for aspiration prophylaxis. However, the literature endorses that additional studies be conducted to resolve the standard dose and to explore long-term implications of erythromycin's use. The authors of this systematic review recommend that further studies be conducted to establish the minimum effective and safe dose of erythromycin. Studies should comprise a large patient population that includes fasted and non-fasted patients. To reflect the current surgical population of today, a variety of age groups, including pediatrics, and an array of comorbidities should be included in future studies. These studies should be double-blinded with a placebo and control group established. Further studies should be performed to determine long-term implications of erythromycin's use, particularly regarding its impacts on antimicrobial resistance.
The following 3 slides include studies and resources utilized in this systematic review. This concludes our presentation. We thank you for your time.